What is primary biliary cholangitis? What is the general demographic of those affected, and when are most patients diagnosed?
Primary biliary cholangitis is an autoimmune liver disease that affects the biliary epithelial cells within the liver. It starts with reduced bile flow and can lead to progressive liver scarring and ultimately cirrhosis. It affects about 35 per 100,000 people in the population. The combination of positive antimitochondrial or PBC-specific antinuclear antibodies with raised alkaline phosphatase is over 95% specific and sensitive for diagnosing PBC. Nowadays, liver biopsy is no longer part of routine diagnosis unless someone does not have the classical antibodies or if there is a suspicion of an overlap syndrome with autoimmune hepatitis. Many patients are diagnosed in their 60s, but those presenting under 45 years of age have a higher risk of poor treatment response and needing liver transplantation.
Approximately 90% of PBC patients are women. Can you shed some light on why this is?
The cause of PBC is not yet fully understood, but there are both genetic and environmental risk factors. 90% of patients are female, and we don't know why so few males are affected. However, it is possible this is related to hormones, particularly estrogens, and one risk factor identified in some studies is recurrent urinary tract infection, which are commoner in females. First-line treatment for PBC is with ursodeoxycholic acid, which reduces the proportion of toxic bile acids and stimulates bile flow. Used at a therapeutic dose, it is a very effective therapy for many patients and improves long-term outcomes and liver transplant-free survival. Delaying starting treatment is harmful, so therapy should be commenced as soon as possible after diagnosis. A proportion of patients do not have a complete response to ursodeoxycholic acid. Risk stratification to identify high-risk patients is crucial, and we now have two options for second-line therapy. Obeticholic acid is a farnesoid X receptor agonist, which protects liver cells from toxic bile acids and stimulates bile flow. Its commonest side effect is itch, which limits its use in some patients and may necessitate escalation of pruritus treatment. Fibrates are peroxisome proliferator activated receptor agonists. They are anticholestatic and improve itch rather than worsen it. However, they carry risks of acute liver injury and kidney impairment. Both medications can lead to complications in people with advanced cirrhosis, so the potential risks and benefits should be discussed in a multidisciplinary team setting and with the patient.
What is the burden of PBC on patients, and what are the treatment options?
The major predictor of long-term outcome in PBC is the degree of improvement in liver blood tests with medical treatment. However, in addition to disease-modifying therapy, we must focus on symptom management. Some patients have a significant symptom burden with a marked negative impact on quality of life. The main issues are fatigue, cognitive symptoms, and itch. There are a number of treatment options for itch, and liver transplantation can be used if all of these are ineffective. However, fatigue and cognitive symptoms remain a real challenge for patients and clinicians alike, with no effective therapies. There is a lot of research ongoing to further improve our management of PBC. Trials historically focused on improvement in liver blood tests. However, the clinical and research community now recognise the importance of patient quality of life, with an increasing focus on identifying therapies for symptoms.
What challenges do PBC patients face in healthcare settings and more generally?
Stigma is a pervasive issue within liver diseases, and I think PBC patients face in healthcare settings stigma in a number of ways. So, one, PBC is an autoimmune condition. It's nothing to do with alcohol or drugs or anything else in terms of input into the body. So it's important that clinicians are aware of that general principle. We'd also like, I think, general clinicians to know that PBC is more than just your alk phosphorus hill. So quality of life is important. Symptom severity, symptom burden is absolutely vital in terms of living every single day with PBC.
What role do you see for patients and patient groups in research?
I think patients and patient groups have a really important role in research. And we would love to see, for example, every single research project, not just in PBC now, but every single research project having patient advocate and patient input right at the start when we're looking at trial design. When we're also, so for example, if there is a clinical trial, involve a patient advocacy and support group in terms of being the first point of contact if patients have any concerns about their role in the trial. So nothing to do with the technicalities, nothing to do with the compound, but actually the patients seeking advice and guidance in terms of the patient role, what their rights are, if it's the right thing for them. Again, just a natural, neutral body which has the patient's interests at heart that can maybe be involved in help.
What national or regional policies could be implemented to improve the lives of PBC patients?
In terms of improving the life of PBC patients, I think there are two major things that would make a huge difference. One, we really need to address the requirement at the moment, which is to do with placebo arm trials in PBC disease progression. When we know the data that tells us about when a patient is out with, for example, the upper limit of normal on their ALK phos, we know the time spent out with normal, we know the severity or the degree to which the patient is out with normal has an impact in terms of life expectancy, in terms of response, in terms of a whole number of aspects of living with PBC. And it's really, really important that we start to address that. So knowing this, we need to look at better ways of running clinical trials that we are not expecting patients to be on placebo for 26 weeks, 52 weeks, even 2 years. We know the data, we know the science, and we know now that this is absolutely unethical and unacceptable. And the other thing that we would love to see implemented to improve the patient lives in terms of living with PBC is the standard of normal being normal. Not 1.67, not 1.5, not the, normal is normal. Normal in terms of liver biochemistry, in terms of patients living with the condition, their symptom burden, and their quality of life. Normal absolutely has to be the new normal.